So we're finally at like learning diseases, but again, I went through all that in the beginning because when you go through these, you'll see where these things will start popping in again. The historical things, the physical exam. Yes.
Sorry, is it going to be like for the exam, like more conceptually using the stuff from the first?
No, I'll ask you questions.
Or directly about?
Yeah,
Okay.
but it's related to like on your physical exam,
Yeah.
what is important with this or something like that. It'll be related to like what we're learning, but it's this stuff. Okay, so moving on to neuromuscular disorders. So we're gonna start with spinal cord and work our way out from there. Nerve disorders, neuromuscular junction, and then finally some muscle disorders as well towards the end. So again, gathering information. First thing to find out, is it weakness or are you having neuropathy? Are you having sensory problems or are you having muscle weakness? Figure that out first. Then we'll figure out, is this a central problem or a peripheral problem? Is it with the central nervous system or peripheral? Some sensory deficit definitions. Numbness is a sense of heaviness or deadness. Okay, if you sleep on your arm funny, it goes numb. On your leg weird, it goes numb, and then it comes back later. Paresthesia is that abnormal sensation of burning, tingling, pins and needles. That's paresthesias. So on your HPI, if a patient comes in complaining of pins and needles, you cannot put the word paresthesia in your HPI. Why? It's not what they said. The patient will not say paresthesia. They're going to say pins and needles. The HPI is only what the patient says. You, in your diagnosis and your symptoms, will say paresthesias, but you can't use that word. Neuropathy is disturbance in the function of that nerve. Peripheral neuropathy is dysfunction of your peripheral nerves. Radiculopathy is that referred pain along the dermatome. So I said like sciatic pain. Sciatic pain is going to follow the distribution, I think it's S1, all the way down and see wherever S1 goes, and that's the pathway that their pain may be in. So that's why the dermatomes are important. Plexopathy is disturbance in the distribution of a nerve plexus. Myopathy is a muscle disorder. So just again, some definitions as we start going through all this. Neuropathies, most are classified as sensory motor. What does that mean? It involves sensory and motor. It does both. Some are either motor or sensory. So as we go through these, you want to know which ones are primarily motor, which ones are primarily sensory. Guillain-Barré, hepatitis, lead poisoning. These lead to motor problems. What motor problem do patients with liver failure get? With hepatitis. I think you guys learned about it. For the wrist flapping? You learn about wrist flap? Okay. Sometimes hepatitis patients get a wrist flapping. It's a weird phenomenon they get. Sensory, leprosy, some solvents, hereditary, they're just sensory, but they don't feel anything. I'm sure you've heard the story about some person that doesn't feel pain. They don't have, like, the nerves don't work for pain. They don't get any pain sensation. So that is a pure sensory problem. There's no motor deficits. It's just sensory. Our peripheral neuropathies is a common feature of many systemic diseases. Okay, diabetes is a systemic problem that causes neuropathies to form. So it's a systemic disease that manifests itself as a neurological problem. And a nerve has very limited ways to respond to injury. Either it can damage the axon, disruption of the axon, or degeneration of the axon. It pulls away. Pulling away is what happens with ALS, which we'll get to later on today, if not on Monday. The nerve pulls away from the muscle, and if there's no nerve on the muscle, will that muscle work? Nope. Muscle weakness can be a result of disease of the muscles or the nerve that supplies them. So when we went to that history and physical lecture, and I had those nerve roots, and I said, what muscle does it go with? What reflex does it go with? This is where it's important because you can look at and you can isolate what nerve root is causing the problems before you even get into any imaging, because it's all on the exam. So paralysis is a complete absence of strength. So also called plegia, which is total paralysis. So hemiplegia, both limbs, one side of the body. Paraplegic, both legs. Quadriplegic, all four limbs. Depends on where in the spinal cord your injury occurred. If you had a lower back spinal cord injury, everything below that is going to be affected. So mainly your legs, your upper body will be okay. If you have an injury in your neck, everything downstream of that is going to be affected. So if you have a really bad neck injury, your arms won't work, everything down, and so forth. Paresis is the less severe weakness or incomplete paralysis, so hemiparesis. So if they come in with a transient ischemic attack, where they'll have neural deficits for like 24 hours and it goes away, they're going to come in with hemiparesis or hemiplegia. Hemiparesis because half their body is down and weak, but it comes back later. So it's temporary. Myopathic disorders, weakness that is usually more proximal than distal. So what does that mean? Where are they going to have their major problems? So what joints? Shoulders, hips. That's where a lot of their problems are going to muscle weakness, the shoulder girdle and the hips. Because the muscle weakness in these type of disorders is primary myopathic disorders. Larger muscle groups are affected more, so shoulders and hips. No muscle wasting or depression of the DTRs until much later stages of disease. Normal abdominal and plantar reflexes. What is that looking at? Brain reflexes. Remember, those two go to the brain. This is not a neurological problem. This is a muscle problem. So the nerves work fine. No sensory loss, no sphincter disturbances, so they're still intact. Neurologically, it's still there. You'll see that with these other disorders, which we'll get to later on. So when we're doing our assessment of a patient coming in with neurological complaints, first thing, is this a weakness due to a primary muscle disorder? Do they have something that's giving them the weakness to begin with? Is it a motor neuron disorder? Is this an upper motor neuron problem or a lower motor neuron? So there was that table we went over the other day about bulk muscle, what happens to their fasciculations, their DTRs with an upper versus a lower motor neuron. This will clue you in what kind of symptoms are they having. And then, is it a sensory deficit neuropathy? Is it focal, just one area that's causing the problem, multifocal? Symmetric, that's very important to note as well. Are you having these problems on both sides of the body or just one? Proximal, distal, again, where is the weakness coming from? Historical factors, the onset of the symptoms. When did your weakness start? When did your numbness start? Okay, when did you notice you have this slurred speech start? Always have to know when things start, the timing. If it's abrupt, vascular, stroke, TIA. Subacute over days to weeks, neoplastic, inflammatory, infectious cause. Over months to years, those are your more slow-moving processes. Endocrine, degenerative problems, hereditary. These are slowly progressing. They take a long time to start. If they have a progressive increase in the motor deficit, suggests that that continuing activity is still going on. If it's episodic, like multiple sclerosis, where they have these relapses and remissions, where it's episodic, or migraines, they come on and come off, vascular or inflammatory origin. If it's steadily progressive, the weakness is getting worse and worse and worse. There's no remission of it. It's just getting worse and worse. Neoplastic disorder or degenerative disorder, where they're just getting worse and worse, keeps degenerating. And if there's rapid fluctuations over a short period of time, that's usually like a myasthenia gravis. That usually will be with that one. Your focused physical exam, muscle appearance. Do they have any fasciculations, any twitches? Okay, muscle tone, strength testing, reflexes, do your full neuro exam, sensory, look at their gait, how do they walk? Okay, do they have a wide stance, which means they have balance problems? Can they do the heel to toe walk? I mean, all these different things, look at the way they walk, and you can go from there. So again, here are the 5 things that it can be when they come in with these muscle weaknesses or sensory problems. So let's get through some spinal cord problems. The first one, when we're dealing with these spinal cord disorders, is red flag symptoms. First one always is trauma. Were you involved in any accident, any problems? So that's where you start with your plain film x-rays, make sure there's nothing broken that's impeding, causing these issues to happen. Pain worse at night, ask these questions. Again, malignancy, that spinal cord tumor. And do they have any bladder or bowel incontinence? So anyone with low back pain, new onset, numbness, tingling, these are the questions you kind of want to ask all the time. So for your ROS questions, these are the ones. So first one is a total spinal cord transection. You're involved, obviously, the epidemiology. The big ones are going to be your motor vehicle accidents. Okay. Why motor vehicle accidents? Whiplash. The immediate stopping, your head still goes forward, and you can, depending how fast, like over 20 years ago in Daytona 500, Dale Earnhardt, he hit a wall going, I don't know how fast he was going, but pretty much he was dead instantly. His head went forward and severed the spinal cord. And then, since then, now they have new type of, called head and neck devices, where they have to, their head is attached to the seat as well, to prevent that whiplash if they get into an accident, so they don't transect their spinal cord. But again, motor vehicle accidents, falls is the next one. Okay, people hanging up Christmas lights off of a ladder and they don't set it up properly, they fall off. That's another cause for these total spinal cord transections. Sport accidents happens a lot. Obviously, football, these high velocity. We'll get to it later on, but you know what sport has the highest incidence of concussions mostly? Gymnastics. They fall, they hit their head. So when you have a total spinal cord transection, immediate flaccid paralysis and loss of sensation below the level of the injury. Immediate flaccid paralysis. Okay, what motor neuron is not working if you have immediate flaccid paralysis? Lower, right? The lowers aren't being given anything, so nothing is telling the muscles to work. So all those lower motor neurons, that upper motor neuron got cut. So nothing is telling any of those nerves what to do below the injury. So nothing happens, immediate flaccid paralysis. Loss of sensation below the level of the injury. Now we have a total spinal cord transection, so nothing is getting up or down. So no motor can get down, no sensory can get up. So that's why you lose everything below. The biggest problem with these things is management of the patient. You're not going to solve their spinal cord transection. You're not going to repair it. So what we have to do is monitor everything that's going to happen because of that injury. Spinal shock is the big one. Loss of reflex activity, hypotension, so these people are going to have immediate shock. Loss of control of their blood pressure. They need immediate fluids, get their blood pressure back up again. They may have the flaccid areflexia that may last hours to weeks. Think of it as like a concussion of the spinal cord. Kind of gets shocked a little bit and gets stunned, and it doesn't really want to work well for a little bit. The heart does it too. Remember, after a heart attack, you can have that stunned myocardium, where for the next month or two, the heart won't work as well, but eventually it picks up again, and you check it again after 3 months. The brain can do the same thing. So look at the soft tissue swelling and so forth. So basically, this is what happens. Imaging, obviously you can look at the bone damage. MRI can be performed to look at the extent of how much of that spinal cord was damaged. But again, the biggest thing, management of this patient. They go right to the ICU. Continuous monitoring of vital signs, cardiac rhythm, oxygen, and neurosigns. These patients usually get neuro checks by the nurse every 2 hours. So every 2 hours, the nurse will go in and do a full neuro check to see what's going on with that patient. Complications. We have to look at this globally. This is why we do things in this class, in our program, in a certain order. We do all the cardio and the pulm stuff first, because everything else kind of like bleeds into it. So cardiovascular, they're going to be in neurogenic shock, part of that spinal shock due to the transection. It's that distributive shock, low blood pressure, low heart rate. Okay, autonomic pathways are disrupted. Respiratory, watch out for respiratory failure. Pulmonary edema, pneumonia, especially like aspiration pneumonia can happen very easily in these patients. Pulmonary embolism. What are these patients not going to be doing? Walking. So you have to worry about the next one, your DVT-PE prophylaxis. Any patient going into the hospital, in the back of your mind, think about clots. People go in the hospital, they don't move very much. They're going to be bedridden, depending on what's going on. A patient like this, they can develop clots very easily, and if you don't treat it, you can make your patient prognosis a lot worse now if you add a PE to the story on top of the spinal cord transection. So watch cardiovascular response, watch the pulmonary response, make sure the breathing is controlled, and obviously watch for DVT-PE prophylaxis. Other complications to watch out for. Pain control. Be very careful with opiates because of the depressive qualities of the opiates. Pressure sores. If they're going to be bedridden for a while, they're going to be in bed for a while. Pressure sores happen whenever bone is compressing skin for a long period of time. They mainly occur in the buttocks from the sacral decubitus, from that sacral bone pressing. And if you know what happens when you do your cap refill, what are you pushing out of the tissue? Blood. So you're pushing out the blood. So if you just keep that finger pushed and just leave it there for hours and hours and hours and days, eventually that tissue won't have blood. It'll become necrotic. It'll go away, and you start getting wounds and ulcers, and it gets worse and worse. Heels is the other one because the calcaneus bone will push on the fat pad and eventually just ischemic changes. So use air beds. You can order an air bed. They're inflatable mattresses. Not as much pressure on the bones. Urinary catheterization. Can they control their bladder function? If they can't, you need to control it for them with the catheter. You can try an intermittent cath afterwards to avoid infections if they can get their normal function back. GI stress ulcers. Okay, we learned about stress and how it increases your gastric acid. Well, guess what's going to be going crazy in these people? Histamine, from all the inflammatory stuff going on. Well, what's going to happen with all the histamine? Increased gastric acid secretion. Watch for PPI. So give them PPI. Watch out for the ulcers. Paralytic ileus. Basically, the bowel stops working. So there's no bowel sounds. Nothing's moving. They're not passing any gas. It's just kind of everything freezes. So bowel motility. So you can't give them any food. Don't give any patient any food until they pass gas or go to the bathroom. If they have passed gas, that means their bowels are working again. Things are moving, you can start eating again. But if nothing is working, don't give them any food. It's not going to go anywhere. Cause problems. Temp control, especially those with a C-spine injury. Okay, they will lack vasomotor control and they can't sweat below the lesion. So be careful for environmental control with these patients. Functional recovery, PT, OT, eval, as soon as possible. And then nutrition, you have to consider long-term feeding. If the patient can't swallow, how are they going to get nutrition? Parenteral, they're going to need a G-tube. What are you going to do? So things to think about going forward. So again, this is a neurology complaint, but if you look at all the treatment, it's all everything else. Nothing really with neurology itself. Some other drugs we can give, methylprednisolone, your steroids, has helped a little bit, but be careful if it's a penetrating injury, like they got stabbed. That's a penetrating injury that causes spinal cord transection to occur. Be careful with steroids there. Immediate immobilization and surgical fixation. So especially on the football field, what they'll do is they'll leave the helmet on them and just take the faceplate off and immobilize them that way until they can get them to the hospital. Instead of trying to get the helmet off and move things around again, they just leave it on there, immobilize it, and get them off the field. Painful spasms, you can give baclofen. So baclofen is a really good drug for spasms. Again, treatment, symptom management. We're treating the symptoms that they're getting. Prognosis, 4 to 20% will have an early death. What factors go into that is the patient's age. Obviously, the extremes, very, very old, very young. The level of the spinal cord injury. Lower level ones, lumbar, better prognosis than a cervical one. There's less involvement, more things you have to worry about with a cervical and up. And obviously, what's their neurological status after everything is calmed down? Tells you what their prognosis is like. Okay, that was a total spinal cord transection. We cut the entire cord right in half, no communication at all from top to bottom. The next one is a Brown-Séquard syndrome. This is a partial cord transection, usually from a penetrating trauma for this one. So in this case, what we're going to do is we're going to say that we're going to knock out 1/2 of the spinal cord. And when we go through this, we're going to review all the spinal nerves again. You'll see what happens at the level of the injury, above the injury, and below the injury when we go through this step by step. So just to review, dorsal white column, the fasciculatus, gracilis, and cuneatus, discriminatory touch, 2-point discrimination, proprioception. Is ipsilateral, so wherever the lesion is, you're going to have loss of these things on the same side of the lesion. Where does these cross over? In the medulla. Very good. The last two are our sensory. Again, how do we know they're sensory? Spinothalamic. They're going from the spine to the thalamus. That's a sensory pathway. Lateral spinothalamic, pain and temperature. Anterior is light, touch, and pressure. These are contralateral lesions because where do these cross over? At the level of the spinal cord where they enter, and that's where they cross over. So if I damage left side of my spinal cord, I'm going to lose these sensations on the contralateral, the opposite side. The last one is motor. That follows our lateral cortical spinal tract. Again, cortical spinal from the cortex to the spine. Motor goes down that way. Motor is also ipsilateral because where's the crossover for motor? Medulla as well. So when the crossover is in the medulla, your injury is going to be on the same side. If the crossover is in the spinal cord, the injury is going to be opposite, contralateral side. So we're going to look at it as above the injury, at the level of the injury, so just T10, and then finally below the injury. And we're going to see what happens when we look at this in 3 different ways. So remember, our sensory goes in here. We'll do pain and temperature in red first. Pain and temperature is a crossover at the level, right? I'm just going to draw one line. I'm not going to draw every single neuron, but remember how many neurons are in a sensory unit? 3. So we cross over and we go up. That'll be in red. And we have blue. Blue will be proprioception. So when blue goes in proprioception, does it cross over or does it stay on the side? Stay on the side. So it just comes in and goes up. And let's do a motor one. Motor comes down. Where's my motor? Okay, so it comes down. And the motor also crosses over before it leaves. Okay, we're going to redraw this every time anyway, so it doesn't matter. So the first one we're going to look at is below the injury. So the injury is all of this on T10. Okay. So pain and temperature below the level of the injury on the right side. Will I have on the right side any pain and temperature sensation below the level of the injury?
Yes.
This is the right. No. On the right. Pain and temperature below the injury, no, because it's got to cross over and go up through it. It's going to get hit. On the left side, pain and temperature below the level of the injury. Will I have any problems with pain and temperature on the left side?
Yes. No.
It's totally fine. We're good. Pressure and light touch follows the same thing as pain and temperature. Will I have any sensation of pressure and light touch on the right side below the injury?
No.
No. Will I have on the left? So remember, I'll draw this in green because we're doing it for this one. On the left side, it comes in, crosses over, and goes up. We're okay. Let's look at the right side. Comes in, crosses over to the right, goes up. Oh, I got blocked. I can't do it. That's why the right loses it for pain and temperature and light touch. Everyone good there? No? Okay. Let me do a different color. Okay. Okay. This is pain and temperature, light touch and pressure. They follow the same pathway. Yes?
So I have a question, because you put right and left, but wouldn't that be the right side, because that's ventral, like this way? Oh, wait. Okay, never mind. Okay, so like the person's facing that way. Okay, never mind, I get it.
So, light touch and pressure, pain and temperature. They follow the same color. Let's look on the right side. It comes in. We're below the injury, so we're only dealing with T11. Right? Comes in, crosses over, and then goes up. Can that signal go up?
No.
Because we're blocked at T10 has been cut. It's trying to go up, but T10 is cut. It will never go up. That's why you lose it on those sides. Now, vibration, proprioception. I'm going to do it in a different color. I'll do it in yellow. Hopefully you guys can see it. And let me make it thicker. Okay. Now, vibration, proprioception. Where does it cross over? Medulla. So we're coming in from T11, and we go up. But can I? No. Let's try the other side. I come in and I go up. I'm good there. So, vibration and proprioception. On the right side, do I lose any sensations? No. So we're good. Do I lose vibration and proprioception below the lesion on the left? Yes. It's down. Does not work. Now, our upper and lower motor neurons. On the right side, will there be any motor problems on the right side below the injury on this patient? No. Nope. Everything's good. Now, the left side, below the level of the injury. We're not talking about at T10, we're looking at T11 down. What nerve has been cut going down below the injury, the upper or the lower motor neuron? The upper motor neuron has been cut, and I'll draw it in a different color. So if our upper motor neuron is coming down, it got cut right there. But the upper motor neuron, it still exists going down. It just got cut. Can't communicate anymore.
So the crossover for the lower motor neuron is at the contralateral anterior gray horn, and then it becomes the lower motor neuron?
Where it synapses at the anterior gray horn.
Of the opposite side of where it came down.
Yes. Now, only the upper motor neuron has been cut in this situation, right? Because here's the orange. This is the upper motor neuron coming all the way down, and it goes all the way down. It got cut right here at T10 because I damaged T10. I haven't drawn it yet. But will this upper motor neuron communicate anything below the lesion? No. So, below the level of the lesion in a brown sequard, they will exhibit upper motor neuron lesion on the left. So you have to go back to that chart and look at what type of symptoms does an upper motor neuron lesion have. Hyperreflexia. You got a question?
So does a lower motor neuron get cut at T10?
Yes, we'll get to at the level in a minute. So this is just looking at below. This is just T11 down. So this is what happens below the level of the lesion. So if I said you have a left T10 injury, right side below the injury loses light, touch, pressure, pain, and temperature. The left side will lose vibration, proprioception, and exhibit signs of an upper motor neuron disease. This is below the injury. They went okay. Yes?
So it's below the injury because it happened at the upper motor neuron, right?
Yeah, the upper motor neuron got cut.
And if it was the lower motor neuron, the injury would happen above because it happened.
We'll get to that, but it's going to be at the level. Because at the level, if we obliterate, if you think each level is an outlet, and at this level, I obliterate that outlet, I destroyed the lower motor neuron and the upper motor neuron in a way, so the lower motor neuron won't work, which we'll get to in a second. So this is below. Now let's look at the level of the injury. So now we are just looking at what happens at the level. So this is just at T10. So think about it. What's the dermatome for T10? Where does it go? If this was L4, and I talk about L4 having a problem. No, where does L4 go? What's the reflex for L4? What's the muscle group for L4? You see where it's starting to come into play, where you know where the injury is. Know what motor groups are fed by that nerve root. What dermatome is that nerve root? And you see where the problems happen. So at the level of the injury, pain and temperature on the right side. On the right is going to be okay. The left, you lose everything, and you have a lower motor neuron. Wait a minute.
But you have to cross over. Still at the
Okay.
only the vibration and proprioception on the right side. You should be able to go like this.
So, guys, don't think too much hard into all this. Just know that it magically happens. Just, you know what? You can go right to this one. Here. Here's the summary one. I'll make it easy. Just remember this one. If you don't want to draw it out, remember this one. So,
So don't follow the.
you can. It's all the same thing. I mean, it's all the same.
Then how does that work?
This is why I'm saying it just magically happens. Just it can still get across. Somehow it still works. It's just like the synapse is destroyed.
That the drawing doesn't.
Yes. So the lesion is T10. At the level of the lesion, which is where this red box is, T10, you lose all sensation and you have a lower motor neuron at T10 itself. Opposite side, impaired pain and temperature sensation. Same side, proprioception, two-point discrimination, and an upper motor neuron lesion. Yes?
Why is it lower motor neuron at the level and not upper?
Because you're destroying the lower motor neuron that were at synapses as well. So the synapse is gone. So you destroy where they started from. So kind of like you destroyed the prongs that go into the outlet.
And not the outlet.
Yeah. So remember this for Brown-Séquard. Remember this one. This slide. Okay. This. Yep. So that's the summary slide for Brown-Séquard. Half. It's a hemisection of the spinal cord. Only half of it's gone. What happened now? This is at the level of the lesion. If I said it's at C4, just everything gets moved up. Where is the lesion? Know what happened. Everything will always be this way. If the lesion is T4, the nipple line, everything stays the same. Everything stays the same. You just where you start from. Whether you're below the lesion, it's always the same things. At the level of the lesion, it's always the same things for Brown-Séquard. Yes?
The lower motor neuron lesion at the level of T10, the upper abdominal reflex will be missing for like since it's T9, T10, and then it's the upper motor for the everything downwards. So then that one would still be intact.
You're talking about for abdominal reflex going to the brain and coming back down? Yes, for the T10, it will still work, but the ones below probably won't because you're losing the sensation below. I think for, was it T10, T9 and T10 for below? Okay, I'm not sure on the abdominal reflex one.
But I thought that was a brain reflex.
It is, but remember, you have to go up, and you have the upper motor neuron has to come back down. And if you can't get past T10, what's going to happen? That's what she's asking. So let's go into the management of Brown-Séquard. Trauma is the big one that causes it. Motor strength goes down, fine touch position on the side of the injury. Loss of pain, temperature, sensation on the side opposite the injury. Bladder function may be spared. And remember where they cross, where they decussate. Early treatment, steroids. A lot of the first line treatment for a lot of these neurological stuff is going to be steroids to reduce the inflammation of the nerve. High dose pulsing at first, evidence is still a little bit limited. Neurosurgical consult gets involved to see what they can do for that transection. And obviously prognosis is poor depending on the severity, location of the transection, where it happened. Epidural spinal cord compression, this is that tumor pressing on the dural sac. Often metastatic. So anyone with a history of breast and lung, here's prostate is there as well. They have a risk of getting a spinal cord tumor when the metastases of that tumor spreads. Presents with pain, especially at night. Thoracic spine is mostly affected because that's where the tumor usually grows. May get weakness and some radicular sensory symptoms. Lower motor neuron deficits may happen, incontinence, paraplegia as well. Can cause permanent neural impairment even if treatment is delayed for a few hours. Pain is going to be that most common presenting symptom. May be incapacitating at night when the patient's recumbent because, again, they're compressing that spinal cord onto your spinal cord, and it's causing issues. Obviously, watch out for any metastases for these patients. Here is the spinal cord tumor. And you can see how this thing is jutting out into the spinal cord. So whenever you lay down, that is compressing, and there's another one down here too. Here's the other one. You see how it's pushing and compressing that spinal cord. These are spinal cord, the tumors in the spinal column, the bone, causing the compression to form. Okay, so those are epidural spinal cord compression, urgent CT MRI for anyone with a neurological abnormality on exam. So they're having weakness, sensory problems, or something going on in that exam that you found. Emergent referral to neurologist and oncologist. You gotta get them both involved. This is a tumor, they need to know the growth and whatnot. May need immediate radiation to shrink the size of it. Prompt treatment to improve outcomes. And obviously you want to avoid permanent nerve impairment. So this is why this pain that's worse at night when you lay down is one of these must not miss symptoms, because you can treat it and help them. Here's our herniated disc, intervertebral disc prolapse. The nucleus pulposus herniates and presses on the nerve root. So you see here, nucleus pulposus, it pushes in and it compresses those nerves. What nerve is going to be hit first? The motor or the sensory? Motor, right? Because the way it's set up. Motor's right. How do you know this is a spinal nerve? Ganglion right there, it's thicker. That's always going to be sensory. Also, this is ventral, dorsal. Ventral is always motor, dorsal is always sensory. So sometimes herniated disc, they can have motor problems only, if it's a very minor, only pushing on that motor nerve. But if it gets bigger, then it's going to be motor and sensory. And then you start getting the weakness and the numbness going down the leg. That's basically what a herniated disc is. May come on with heavy lifting or not. And radicular symptoms will usually happen along that dermatome down that leg. Sometimes you'll hear people that say they have a pop, or they hear a popping noise, and that could be the herniated disc happening. Cauda equini syndrome is a centrally prolapsed disc. So in this picture, you see how we're pushing it on the side? In cauda equini, this is pushing right on the center of the spinal cord, so both sides are going to be compressed, both sides will be affected. So because both sides are affected, they get what's called saddle anesthesia. If anyone ride horses, being in a saddle for a while, your butt gets numb, I guess. Same thing happens here. Saddle anesthesia, your butt gets numb, the girdle gets numb, because you don't have any sensation, because you have a compression that's pushing on both sides of the spinal cord. Bladder and bowel dysfunction as well as here. This is why that's another must not miss symptom. If they lose bladder and bowel function, be worried about cauda equina. Yes?
What's the difference between like bulging and herniated? Are they just using intertwines?
Intertwined, I think. Herniated is actually the medical term for what actually happens, where like hiatal hernia, where part of it bumps through. So a hernia just means that it's popping out where it shouldn't be. The hernia or the bulging disc is because it's bulging into the spinal cord, causing problems.
But does it mean always that like the nucleus part is like coming out?
Sometimes it could be a disc out of place too, but usually it's the proboscis. Urgent MRI, urgent consultation with neurosurgery, because that needs to be fixed. That compression needs to come away. So here it is right here. You see how it's pressing on the middle, not off to the side. So both sides are affected. Saddle anesthesia, because you get weakness on both sides of the hips and the pelvis. So assessment of this herniated disc, first start with just plain films to see if there's any, if they have no neurological deficit. CT MRI, if they have a neurological deficit, they have weakness and numbness in their feet, that's new. Persistent pain despite conservative treatment. Get them seen by a neurologist or a neurosurgeon if they have any significant radicular symptoms, such as 3 out of 5 muscle strength. What's normal muscle strength? 5 out of 5, so they're weak. Consider bed rest versus activity versus physical therapy. Pain control for these patients, just some simple analgesics. May need an epidural steroid injection. As with a lot of things you've learned already, you always start from the least invasive and work your way to the most invasive things. When people have herniated discs, they're probably going to need surgery at some point, but insurance doesn't want you to go right to surgery. You have to try other things first. So you start with like physical therapy. And if that doesn't work, then you can try the epidural steroid injections. And if that doesn't work, help your pain, then finally they can probably go for surgery. But they make you try different avenues first. Epidural steroid injection reduces the inflammation and right where all the inflammation is, helps reduce the pressure on that nerve and the pain goes away. That's the idea. And then finally surgery to repair that herniation. ALS, amyotrophic lateral sclerosis. This is also known as Lou Gehrig's disease. This is what Stephen Hawking also had. It's a progressive disorder. So what does that mean? It gets worse and worse and worse. Degeneration of the cortical spinal pathways. So is this a motor problem or a sensory problem? Motor. This is purely motor. So down to the anterior horn cells. What happens in the anterior horn cells? Not so much the cross. There's a crossover. So what is it called when two nerves communicate? Synapse. That's where the synapse is from the upper and the lower motor neuron happens in the anterior gray horn. So if I destroy the anterior gray horn, I'm destroying that upper motor nerve in that area, and I'm destroying the lower motor nerve in that area. And you'll see what happens when we go through that. So they get a mixed upper and a lower motor neuron deficit. They get a mix. They get upper and lower. Weakness, easy fatigability, normal sensations. All their sensory is fine. This is just a motor problem. And usually presents between ages 30 and 60 years old. So there may be some cortical bulbar involvement. So cortical bulbar, what is that really referring to? What are we talking about? What's your cortical bulbar area? You're all pointing to it. It's your mouth. Mouth, yeah. Okay. So look at the problems that they have. If they have cortical bulbar involvement, difficulty swallowing, chewing, coughing, breathing, speaking, tongue fasciculations is a very common finding for ALS. Okay, these are all things, again, dealing with the mouth area. Okay, that's why they have these problems. Cortical bulbar involvement, lack of motor control, they lose these functions. Again, intellect is normal. Think of Stephen Hawking. He was still writing books and theorizing things while he was very advanced with the ALS. So this is our tracks. No, this is just one slide. This is all it is. This is all it is. So, like I said, with ALS, you destroy that and you destroy those. So you lose sensation. That's why you get an upper and you get a lower motor neuron problem. It's a mix because you're destroying where the uppers come down and you're destroying where the lowers start. So you're getting both of them by knocking out those two cortical spinal pathways. Again, no sensory, but they get upper and lower motor neuron. Think of Stephen Hawking. That's really all it is. Yeah.
Where do they synapse in the like? Where do they synapse there? Is it between the horn and the?
Well, the lower motor neuron synapse occurs there. That's where the synapse occurs. The motor neuron, remember, it comes down and then it moves from there where it makes the.
So where's the like issue with ALS? Like,
Because you knock out the areas, like it's basically, if you think about all like these little spots as outlets, if I destroy the outlet on your desk, the plug that goes into it is like the upper motor neuron. That's destroyed. That won't work. And the lower motor neuron that I plug into the outlet is destroyed. Won't work. So the whole outlet is destroyed. Upper doesn't work, and the lower doesn't work. You're destroying the connection, so it won't do anything. Now, because this happens, do I have a picture of it? No, I don't. If this is your muscle, here's your nerve, it starts to pull away. You get nerve degeneration, denervation atrophy. The nerve, because it's not being stimulated, that lower motor nerve is not being stimulated because the anterior gray horn was destroyed. Lower motor neuron is destroyed. It's not going to go to anything. Eventually, that nerve will atrophy and it will pull off away from that muscle. If this nerve comes off of that muscle, will that muscle work anymore? No. That's why they have problems with breathing and swallowing and chewing, because once that muscle is once the innervation to that muscle is destroyed, that muscle won't work anymore. It gets very weak and progressively gets worse and worse and worse. So muscle biopsy may reveal some denervation atrophy. You can get a nerve biopsy. Here's our EMGs again. I want to see, is this nerve conducting from one point to the other point? How well is that conduction going? How fast does it go? Do I lose intensity of that signal? That means that the nerves are damaged and they're not working anymore. So again, fasciculations, fibrillations of both upper and lower limbs. Normal motor conduction velocity, because the nerve itself is working, it's just being pulled off of the muscle. It's just not being stimulated. Normal sensory. So treatment. There really is no treatment for ALS, but again, we worry about symptoms. Riluzole is one that helps with presynaptic glutamate release, may help slow the progression, but again, there's no cure. And again, management of symptoms, spasms. Here's your baclofen again. So for spasms, remember baclofen. Mobility, electric wheelchairs. They're not going to be able to walk and get around. Yes, you have a question?
Yeah, I wanted to ask, like, how do people get this? Is it genetic?
Genetic, or just, yeah.
Like, it's just random, like you just randomly
Mobility, they're not going to be able to walk. Think of electric wheelchairs. Dysphagia, they're not going to be able to swallow because of all the cortical bulbar. They're going to need to be fed. G-tube placement, potentially. PEG tube. Excess salivation. So you give them amitriptyline for the excess saliva. It's an anticholinergic. Remember, anticholinergics, dry as a bat. Is it dry as a bat? Dry as a bone. I know it's one of them. Blind as a bat. Yeah, why is a bat dry? Dysarthria, communication devices. Stephen Hawking had that computer where he just looks at things and it says words for him. Respiratory failure, can they support their airway? Remember, a lot of breathing is voluntary motor involvement as well. They can't support their airway. They may need some positive pressure ventilation. But again, it's a progressive disease and usually fatal within 3 years for it.
If they're not treated for it, will they like die sooner?
That's why it's 3 years. Like, obviously, Stephen Hawking had resources and money to help him along the way. Money is a great cure for a lot of diseases, unfortunately. Okay, so that's it as far as those things are concerned. Now we'll just go over some quick nerve disorders by itself, and we'll finish the rest next week. So some isolated peripheral neuropathies. Okay, facial nerve. If you have a facial nerve palsy, it's Bell's palsy, where half the face is down. It's usually due to herpes simplex. Radial nerve is called Saturday night palsy. If you passed out drunk and your arm was up on a bed and you wake up and your arm is dead, that's basically what that is. Median nerve will give carpal tunnel syndrome. Your ulnar nerve is that funny bone feeling if you hit it weird, that weird tingling in your arm. That's the ulnar nerve. Lateral femoral cutaneous nerve, it gets damaged. It's called neuralgia paresthetica. Your deep peroneal nerve can cause compartment syndrome. That's a surgical emergency. And your posterior tibial nerve gets compressed. It's tarsal tunnel syndrome. So here's your Saturday night palsy. Carpal tunnel, obviously where that stuff goes through. More females than males may have it. Risk factors, obesity, any coexisting conditions. Aromatase inhibitor use, and repetitive hand-wrist use. Also, don't forget the neck is involved with carpal tunnel as well. Especially people who are at a computer all day, their neck goes forward to look at the computer screen. And like that constant movement forward can cause like problems as well. So again, knowing your dermatome patterns will tell you, is this a radial nerve or an ulnar nerve? Compression, carpal tunnel, that one is going to be in that distribution. So if they come in complaining of pain in those fingers, we know it's that nerve. Worse at night, worse with activities with the hands, and they're going to have remission and exacerbation. Will it get worse, and then it'll get better. A couple of maneuvers you can do for carpal tunnel. One's called the Phelan maneuver. You flex with your wrist at full extension and see if that causes any pain with that. That's one sign you can do. The other one is the Tinel test. You percuss over the median nerve and see if it causes any pain when you do that. Any paresthesia, pain on the median innervated fingers with percussion over that nerve. So these are just two physical exam things you can do for carpal tunnel. Testing, EMG, nerve conduction study, see what's going on with the conduction of the velocity of that nerve going from the shoulder all the way down to your fingertips. Imaging, if you think there's some sort of structural thing that needs to be ruled out. Otherwise, you don't need to do imaging per se for carpal tunnel. Treatment, surgical decompression is usually the big thing that's going to happen and do the most. If they failed it, you can try glucocorticoid injections for that as well. But usually a surgical decompression, you just decompress that nerve and the pain goes away. Multifocal peripheral neuropathies. This are affecting multiple peripheral nerves, not just one. These are usually your systemic and your metabolic problems. B12, we talked about that before. Alcoholism, leprosy, and diabetes. So these are 4 things that cause multifocal peripheral neuropathy. Again, multifocal, usually, when you have carpal tunnel, there's a reason why you have one problem there. It's a structural thing from repetitive use. With these multiple peripheral neuropathies, there's usually an underlying cause. You have multiple of these things. It doesn't happen like that. Multiple sclerosis is one of the major ones we'll be dealing with in this section. Inflammatory process from an immunological disorder. Multifocal, so many different places where it happens. Demyelination of the white matter of the brain and the spinal cord. Every time a new demyelination occurs, a new plaque occurs, is when an MS patient will have a new flare-up. So every time they have a flare-up, that means a new one of these lesions formed. And then the body gets used to it, and the symptoms go away. And then a new one will form. And then they get new symptoms again and new flare-ups. So that's why it comes and goes. And this relapsing and remitting pattern with the chronic course. So again, we're not drawing anything with this one, but just to show you, one, we know it's white matter, so it's only going to be the axons because this is a demyelinating disease, and the myelin is only in the white matter, so that's where we have the problem. So this could be at any level of the spinal cord or the brain. So if this got affected back there, okay, what sensations would I be losing? Vibration, position sense. That's where I would have a problem. And depending on what level, they'll tell you what dermatome or what muscle groups were involved. Out here, okay, pain and temperature. This is where the pain and temperature ones are. So if I have a plaque here, I'm going to have issues with pain and temperature depending on where that goes. Out here is your light, touch, and pressure and whatnot. So you see, depending on where the plaque forms, that's where you're going to have your problem. Sarah, you have a question?
Yeah, is this, so I remember learning about this in last semester. Is this the one where, like, stress and, like, warm baths? Okay.
Yep.
Gotcha.
So mostly in the cervical cord, asymmetric lesions, they're going to happen randomly on one side or the other side. Again, any level of the spinal cord, any part, as long as it's white matter. Distributed in space and time, intention, tremors, scanning, speech. Strong genetic component, Caucasian, Northern, Eastern European descent, more females than males, usually around mid-30s is when everything will start up. So signs and symptoms, ataxia, positive Babinski, blurred, double, or loss of vision in a single eye. This is one of the big ones they'll have with MS. Okay, double vision is usually one of those big complaints they'll have. Clonus, clumsiness, fatigue, hand paralysis, position sense. Not all MS have the same symptoms because it depends what part of the spinal cord and brain were affected. That's where you have your problems. Okay. Yeah. It could be both. Because again, it's all white matter. So depending on where, if you hit the motor tracks, you're going to have motor problems. Diagnosis is made from clinical and lab features. Okay, what are they showing? What do their labs show? MRI, more sensitive than CT. You're going to see what's called plaques, and they're called Dawson's fingers when it comes to MS. I have a picture I'll show you for that in a second. We also can do an evoked potential test for MS. And what this does, it takes the time, measures the time for nerves to respond to stimuli. So we're measuring speed here. Why is that important for a demyelinating disorder? The myelin keeps that speed going. So if you demyelinate nerves, the insulation goes away, the speed at which it goes from point A to point B slows down. So you'll see those things happening as well because you're demyelinating the fibers, they're exposed, electricity goes away. So you can do this type of test to see what goes on. There's also somatosensory evoked ones, brainstem evoked potentials, but again, we're looking at decline in nerve conduction due to demyelination. So these are these little Dawson's little plaques that pop up. These are the Dawson's fingers, these little projections, and these are plaques, demyelination due to multiple sclerosis. These are the Dawson fingers. CSF abnormalities. Okay, you're going to do a lumbar puncture on these patients. We're going to see what's going on. They're going to have increased immunoglobulin levels. Remember, this is an autoimmune disease We're attacking ourselves. We're going to have immunoglobulins go up. Increased lymphocytes. Oligoclonal bands. This is the important one. These oligoclonal bands is what you will see in the CSF, and this shows that this demyelinating. This is the myelination that gets ripped off. And your myelin basic protein will be elevated because of the protein being ripped off the myelin. It's all right there. Glucose usually normal. Why is glucose normal? No bacteria. This is not an infection. This is an inflammatory process, not infectious. Now, this McDonald criteria, do you have to memorize what it is? No. What do I want you to know? That the McDonald's criteria is used for MS. You all have phones. Hopefully you all have Medscape or some sort of app on there that has formulas. And as long as you remember McDonald's and MS, you just go to your phone, pull up McDonald's criteria, and enter the information, and it'll give you a prognosis. You don't have to worry about memorizing these things. But basically, what is it looking at? How many attacks has the patient had? Remember, relapse and remission. Every time you have a relapse, it's a new plaque that formed. Looking at the MRI number, how many lesions do I see on an MRI? The more lesions, the more plaque deformation that happens, and we get plaque formation. Or your CSF findings, are there oligoclonal bands in there? So basically, we're looking at the severity of the plaque formation, and this is the criteria for doing it. So remember McDonald's criteria for MS. Relapsing and remitting is the most common form of MS. 60% will develop a secondary progressive MS in 15 years, 90% in 25 years. And the secondary MS is just worsening. It's just gradually worsening following those initial relapsing, remitting MS. Yes?
So the symptoms go away because like the spots go away?
No, they just kind of adjust and the inflammation kind of goes away and they get used to a new normal and then they're okay for a while. Then a new plaque forms, they get a new complaint. So, and then here's like a summary slide for multiple sclerosis as far as the symptoms they're going to have, the age and whatnot. Treatment, relieving the symptoms. Steroids help with a severe attack for these acute attacks. Steroids for anti-inflammatory properties. You could also try plasma exchange, which is plasmapheresis. Short-term use for severe attacks if steroids are contraindicated or ineffective. You could also do these disease-modifying drugs for relapsing MS. Interferon is one. These Avenox. Basically, any of these interferons is going to be an MS drug. You don't need to know all those drugs. I'm not going to test you on those drugs. I'll tell you what the drugs I want you to know for that. Reduces frequency and severity of those attacks, may delay eventual disability, reduce the accumulation of those lesions in the brain and the spinal cord, so the accumulation of those plaques. You can also give IV immunoglobulin, may help with the relapses, and exercise is important for these patients as well. Treatment, here's our spasticity, there's your baclofen again. So again, we're mainly dealing with the treatment of the symptoms from the MS. You're not going to stop it, but we can help with the symptoms from it. Drugs to reduce neuropathic pain. You have to know, is this pain coming from a neuropathy that's causing the pain, or is it like a structural muscular pain? If it's a muscular pain, you can give Advil, ibuprofen, those NSAIDs will help with that stuff. Those are not going to do anything for nerve pain. So if you have like sciatic pain, where the nerve is compressed and you have radicular pain, the nerve is what's causing the pain to happen. So you have to give drugs that help with nerve pain. The two big ones to know, well, gabapentin and Neurontin, and pregabalin and Lyrica. The other ones are also used for like seizures as well. They have kind of other effects. But as far as like when you think about neuropathic pain, shingles is a neuropathic pain. The pain is being presented and caused by the nerve problem. So you give acyclovir, which is for viruses. But you would also give like gabapentin or Neurontin because that's going to help with the nerve pain. Shingles patients, nerve pain, give them gabapentin, it's going to help. Drugs to reduce chronic fatigue, amantadine or Simitrel, modafinil, Provigil. Those help with people that sleep a lot. Avoid overwork, fatigue, and exposure to excessive heat. It can trigger a symptom from MS to occur with really, really hot showers and stuff. Prognosis, partial recovery from acute episodes can be anticipated. Again, that's the whole relapse and then remission. You can't really predict that next episode, but who has the best prognosis? Female genders with MS have a better prognosis. If the onset is before age 40, better prognosis. And if the problems are more visual and somatosensory, like double vision, numbness when they walk, those are sensory problems, rather than pyramidal or cerebellar, so rather than motor. And 50% of patients mildly or moderately disabled after 10 years of symptoms. Yes?
Do patients die from this, like ALS or?
MS, I don't think so. I think it's more like symptom control and they're okay. Because they're not really having issues with breathing or vital sign management. Where are we at here? Yeah, we'll stop here. Okay.